ground, cause Vienna turned you down, rejected for painting. Then you were volunteering for the war, getting medals and awards for your bravery. But then they beat you, wanted to deplete you, but never could defeat you. The treaty was too far. You saw the bank, Jews, the pests were all the same. You so white took up and blamed Jews, you made them wear the star. And in jail, the famous book you wrote that took power by the vote and you fixed everything.
The clinical anatomy of spinal manipulative therapy.
So in this talk, we're going to discuss first the definition of spinal manipulation, and then we'll describe the general forces that are used in manipulation. And then we're going to hone in on the anatomic structures that are receiving those forces. And then we're going to focus on the zygapophyseal joints. We'll then weave the results of current research into the talk, and then we'll finish with a discussion on benefits versus risk of spinal manipulation. So to begin with the definition, I'll give you the long-winded definition and then the bottom line here. Spinal manipulation, and I'll be using the term spinal adjusting synonymously, is the use of a short or long lever, high velocity, low amplitude thrust to one or more of the joints of the vertebral column. So the bottom line is it's a quick, shallow thrust. So let's think for a moment about the kinds of forces that are put into the spine during these manipulative procedures. And one of the most common types of forces that are applied is posterior to anterior thrusts. And Dr. Smith mentioned that my dad was a chiropractor. This is a picture of my father. And he is giving a posterior to anterior thrust. So this technique has the $5 name as the cross bilateral transverse pisiform technique. So it is a P to A thrust with some torque involved. Now, Dr. Smith has been kind enough to provide us with a couple of videos showing some manipulative procedures. And the first one shows several different types of posterior to anterior thrusts.
Thanks, Dr. Kramer. So in this video, you'll be able to see me doing some palpation, just checking the spine. Here we have an ulnar border type of thrust, a knife edge thrust, as some people call it, in the sagittal plane. Now the cross bilateral that Dr. Kramer referred to. And then just using hands to palpate and assess the spine in this case here. And then providing thrusts in different parts, in this case, a little bit into the lumbar spine as well.
Excellent. Now, in addition to P to A thrusting, rotary motions are frequently applied to the spine in a variety of techniques, particularly in the lumbar region. And Dr. Smith is demonstrating a very commonly used adjustment here.
Yeah, as Dr. Kramer mentioned, this is a very common type of adjustment. The person is in a side-lying position, and the hand contacts one of a few different forces: spinous process, mammillary process. Here I've got it wrapped around the spinous and inducing some rotation of the spine in order to try to gap the facet or the Z joints that Dr. Kramer will be talking about coming up.
Thank you, Dr. Smith. And so even though rotation is de-emphasized in most cervical manipulations, almost all cervical adjusting has some component of rotation associated with it. Now, this technique is technically not a manipulation, but a mobilization because there's no thrust involved. It's called flexion distraction, and traction is given to the lumbar region in this case, and then the caudal part of the table releases and can flex forward, and that induces additional traction and is a commonly used procedure. So those are the general forces that are involved in manipulation. Now let's think for a moment about what anatomic structures are receiving those forces. And so in the figure here, this is a parasagittal section of the lumbar region. So it's as if I was cut about 1 centimeter to the right and then cut all the way down my body, and the left part of my body flopped off, and you're looking at what's left. And I'd do that for you if I thought it would help. But at any rate, with these forces that are applied, one of the structures that receives these forces are the zygapophyseal joints. The zygapophyseal joints. And so, back this up. I want to get my pointer working here. There we are. So Dr. Smith showed me how to use this laser. I want to try this out. So anyway, here's the superior articular process, inferior articular process, Z-joint space right here. And then here's ligamentum flavum and the capsule behind. I'll show another picture of the capsule in a moment. So the zygapophyseal joints, or facet joints as they're called, also are receiving these forces. The inner body joint and intervertebral discs. So here you see the intervertebral discs. That symphysis type of joint is receiving these forces. Spinal muscles obviously are receiving the forces. We'll talk about how the muscles can be affected through reflexes, spinal reflexes, in just a little later as well. And then vascular and neural structures within the intervertebral foramen are affected by these forces. And then finally, connective tissue, which is a very hot topic in research during the past 10, 15 years, that connective tissue system that is completely interwoven throughout our bodies is also influenced by manual procedures. We're going to focus in on the zygapophyseal joints for the rest of the talk because over half of low back pain, neck pain, and vertebrogenic headaches have a zygapophyseal joint component to them. So this is a computerized tomograph, and on a CT scan, the standard view is that this is the right side. So it's as if this patient was lying on their back, and you're looking at a section through their lumbar region as if you were looking from what were their feet toward their head. So with that in mind, this is the right superior articular process, inferior articular process, Z-joint space here. And then here you can see ligamentum flavum, even on this CT scan. And here's the joint capsule showing up on the CT as well. That's beautiful. All right, now how? So we've talked about, okay, these are the different kinds of tissues that can be affected, but now how are they affected? So we're going to talk about several different current theories on how the zygapophyseal joints are affected during manipulation. And all of these have significant research to back them up. So the first one is the movement of menisci within the Z joints. We'll talk about what that is in just a second. Then the breakup of adhesions within the zygapophyseal joint. And then finally, stimulation of mechanoreceptors within the Z joint capsule and other related structures. And then reflex responses of the muscles and of pain sensation related to that. So these are the three theories we're going to discuss. So just a little more realistic view of the anatomy here. So here you can see so again, a horizontal section through the lumbar region, superior articular process and its hyaline cartilage lined facet, inferior articular process, hyaline cartilage lined facet. Now you can see ligamentum flavum really well wrapping around the Z joint, actually taking the place of the capsule anteriorly. And now we see the Z joint capsule quite well in the back. And here we see dura-arachnoid and subarachnoid space, cerebrospinal fluid frozen for your viewing pleasure. And you see the neural elements of the cauda equina in the lumbar subarachnoid cistern. Now here we see parasagittal cervical images. And so we see inferior articular process, its facet, superior articular process, its facet. Now we see the capsule nicely here. Okay. Now up here we can see a meniscus, a meniscal fold protruding into the joint. Now these menisci are found in every Z joint throughout the spine, cervical, thoracic, and lumbar Z joints. And they protrude into the zygapophyseal joint, and they receive sensory innervation. In this right-hand image, you can see the sensory innervation has been drawn in. And so if these structures are compressed, if they're pinched within the Z joint, as can happen sometimes, it hurts because they receive sensory innervation. But normally they work great. And in fact, they're extremely important in the normal function of the Z joints. Here on this, on the left-hand side, you can see the three layers of first the fibrous capsule, and then this fibrofatty layer of the meniscus, and then the synovial lining. So I'm going to go to the other image. The synovial lining produces synovial fluid, and you've probably discussed synovial fluid. It's basically joint oil, right? Joint oil. And so hyaluronic acid is the primary constituent. Fascinating stuff. When it's compressed, they're very complex molecules. When they're compressed, they glide along themselves, making the coefficient of friction between these two surfaces 6 times less that of ice on ice. I mean, that's smooth. So these are like little oil cans protruding into the Z joints and keeping them well lubricated, which is necessary because these small Z joints are about the size of the intercarpal joints, the joints of your wrist. The difference is they're constantly loaded by that 10-pound bowling ball we call a head, and then whatever our upper extremities are carrying and the weight of our torso. So they're constantly being loaded. And so it's important that they are well lubricated. Gets me so excited I can hardly stand it. So at any rate, let's talk now about some of the things that can go wrong and how they can be addressed with manipulation. So here we see a zygapophyseal joint in section, and here's the meniscus that we've talked about. Now, Mooney and Robertson, two orthopedic surgeons, in 1976 in the Journal of Clinical Orthopedics and Related Research, really for the first time described in a prominent medical journal the mechanisms of spinal manipulation, what their theories were. And the first was movement of these menisci outside of the joint. So this meniscus could move into this area between the capsule and the articular processes. And this would cause pain. Mooney and Robertson felt that this would occur during minor kinds of trauma. If a person's walking uptown in Oxford, for example, and you step off of a curb, you're talking to your friend, you're not really paying attention, step off of a curb without thinking about it, that type of quick jarring motion, Mooney and Robertson felt could cause this meniscus to move into this position. And since this time, other authors have called this extrapment of a meniscus, extrapment of a meniscus. Others have studied this since this time. Webb got her PhD on the zygapophyseal joints in the United Kingdom and discussed extrapment in some detail. And this is an illustration from her work, and you can see she has illustrated this extrapment where the meniscus protrudes outside the joint. Now, Mooney and Robertson, Webb, Linton Giles, many authors have described how spinal manipulation separates the joint surfaces, which I term therapeutic gapping of these Z joints. So these surfaces separate from one another. And when that happens, Webb and these other investigators state that this will come back into its normal anatomic position and relieve the pain. Now, other authors have described another phenomenon with these menisci that most feel occurs more frequently than extrapment, and that is entrapment. And what this refers to is that the meniscus protrudes deeper into the joint and then becomes trapped between these joint surfaces. And as we mentioned, they have sensory innervation, so it hurts when they get pinched. So this scenario is if a person is working in their garden, bent over, working in their garden, for example, for some time, and then the meniscus droops into the capsule. The multifidi muscle, you may recall, attached to the capsule. That's part of their origin. So if when the multifidi relax, when a person's bent over for a long period of time, that allows the capsule to kind of droop into the joint, and the meniscus then falls further into the joint. Then the person stands up quickly. The joint surfaces slam together, compressing the meniscus, trapping it, and they're not even able to stand up. And that's been called acute locked back syndrome. And so several investigators have described that manipulation, such as the lumbar manipulation you saw Dr. Smith give on the side posture, that separates those joint surfaces, gaps the joint, and because the capsule attaches to the two adjacent articular processes, it tractions the capsule, and that pulls the meniscus out of harm's way. And so these are the individuals that likely come in bent over, they receive a manipulation, they can stand up, and they feel great. And if they weren't all that easy, they're not. But that describes that type of scenario. Now, also, you may have had the experience of you're leaning on a table or something, talking to a friend, and then you stand up and you feel a quick catch in your low back. That's probably quick pinching of a meniscus. Or you turn your head, and all of a sudden you feel a sharp burning pain deep in your neck, kind of very isolated. That's probably a meniscus that has been pinched. And now some people will sleep in an awkward position and wake up and they're not able to straighten their neck. And that's likely due to a meniscus being entrapped. So again, Webb in her dissertation work showed an entrapped meniscus as well, and then the therapeutic gapping of spinal manipulation to pull the meniscus out of harm's way and allow normal motion to occur. These structures are actually most appropriately called zygapophyseal joint synovial folds, because by definition, a meniscus is not innervated, and these are, as you know, they receive that sensory innervation. So synovial folds is actually a more descriptive term. So we've talked about movement of menisci. Another theory that is that describes the mechanisms of action of manipulation on the Z joints is breakup of intra-articular adhesions. And we mentioned that Mooney and Robertson had talked about that in their 1976 paper. Others had actually talked about it before that. Joseph Jancy, who was a prominent president at National University of Health Sciences, was probably the first one to really discuss this in the late 40s even. And so in this model, this theoretical model, the Z joints become hypomobile for a variety of reasons. They lack proper motion. So if we sit a lot and don't exercise, these Z joints are becoming hypomobile. If we stand a lot and don't exercise, the same thing. If you're in clinical practice and you have a patient that's doing repetitive motions all of the time, some of the joints may be moving, but others may just be getting loaded over and over, becoming hypomobile. And in this model, these hypomobile Z joints develop connective tissue adhesions within them. And then, as we mentioned, spinal adjusting gaps the joint, separates the joint surfaces. This breaks up those adhesions, reestablishing joint motion. And that reestablishing joint motion can, if done early enough, can potentially reverse or stop degenerative changes from occurring in the joints. And so here's a cartoon drawing of this theory. Here you see a hypomobile Z joint getting these connective tissue adhesions in them. And then here is following a manipulation, the joint surfaces have gapped or separated, and now the connective tissue adhesions have broken. Now, our research group has been working on this theoretical model for over 25 years. So I'm going to spend the next 3 hours going, no, I'm not going to do that to you. But so just very briefly, we'll talk about some of the work we've done. So first we want to look at, does hypomobility result in adhesion formation in the Z joints? Nobody had ever really studied that. So we did this in a series of studies on rats. And all of our work is done under the auspices of the Institutional Animal Care and Use Committee, which runs under the guidelines of the Department of Agriculture. We have a veterinarian on the staff, and all surgical procedures are done under anesthesia and then followed up with 2 days of analgesia. Animals are observed for pain behavior. If any is seen, analgesia is extended. So at any rate, this is a rat Z joint. And you can see the superior articular process here. inferior articular process here, as they're called in rats, cephalad and caudal articular processes. And here's the Z joint space. So the capsule has been cut here. There's a probe that is protruding on the ventral aspect of the joint about a third of the way in. And so the joint's popped open. And this is an 8-week control animal. And this is 12 times magnification. Now, this is an 8-week hypomobility animal, induced hypomobility. And in some of the papers I've sent to Dr. Smith, we talk about how that is induced, how hypomobility is induced. This is the 6 times magnification. I'll show you this, the 12x in a second. But I wanted to show you this because I want you to see that here's a probe going all the way through the joint in this case. It's just about a third of the way through in the previous animal. And here is the capsule has been removed here, but the joint is not opening because, and now as you can see in this 12x, all of these adhesions that have developed in the Z joints. And so this study used 87 animals, and we did find time-dependent adhesion development. The longer the hypomobility, the more adhesions developed in the Z joints. We also looked at degenerative changes. And so here on your left, you can see the superior articular facet of a 4-week control animal with the nice glassy hyaline cartilage. Remember, hyaline means glassy. So the nice smooth hyaline cartilage here. And then in the 4-week hypomobile animal, you can see the hallmarks of degeneration, that's roughening and pitting. You can see the pits here. And so degenerative changes occurring with hypomobility. Then if we look at the outside of the articular process, this is the cephalad articular process, the cephalad surface of it, you can see nice smooth line here in this 8-week control animal. Now in this 8-week hypomobility animal, we see a very large osteophyte developing there. And so we found that adhesions developed between 1 and 4 weeks, and then degenerative changes between 4 and 8, and also osteophytes between 4 and 8 weeks of hypomobility. So back to our cartoon drawing. So we've seen that hypomobility does result in adhesion formation, but does spinal manipulation gap the Z joints? And McFadden and Taylor published in the journal Spine several years ago that they did a study using cadavers and concluded that the joints of the spine do not gap, the Z joints do not gap with rotation. And they stated in their discussion, they strongly inferred that clinicians telling their patients that they were gapping the Z joints were misinforming them. They said they would only gap in the most severely degenerated spines, very rare severe degeneration. But if the joints were anywhere within normal anatomic limits, they would not gap or separate. So we were very interested in this anyway, and this really piqued our interest. So we wanted to investigate this, and we wanted to start by looking at patients that we knew that their Z joints were within normal anatomic limits. So we did a series of studies on humans with magnetic resonance imaging. And here's an example of a Z joint, superior articular process, inferior articular process. And here you can see the Z joint space. This is before manipulation. And then here is after lumbar manipulation. And you can see the Z joint space has increased in size. This was, by the way, the largest gap of this study. But in the 64 subjects, we did see significant gapping between with those who received spinal manipulation versus the controls that did not. And we published the paper in the same journal that McFadden and Taylor published. Their cadaver study, they extended the spines before they rotated them. And as you may be aware, that extension of the lumbar region really locks out rotation. And so during a typical lumbar manipulation, as you saw Dr. Smith do, the patient is flexed, and then the manipulation is given. And that flexion allows the Z joints to gap. So that's why we think that we had the opposite results of McFadden and Taylor. But we wanted to look at low back pain patients because that's what brings patients to us, the fact that they're having pain. So we received additional funding to study 112 low back pain patients and found basically the same thing, the joints gap. This is from that study. This is before manipulation, the Z joint space here. And then after manipulation, you can see the Z joint space has increased. This was not the largest gap by any means in this study, but I chose this image because of this low signal within the center of the Z joint. And here you can see it again right here. And we think this is gas, probably carbon dioxide coming out of solution and entering the Z joint during that popping sound that is sometimes heard during manipulation, which is called cavitation or tribonucleation. But that popping sound is we think is related to this gas coming out of solution. We became interested in this and wanted to study, does that cavitation sound have any relationship to gapping? And so we decided to study this, and we got additional funding to do that. And so we used these piezoelectric accelerometers. They're about the size of a sugar cube. We put them in very specific locations on the lumbar region so that we could identify the Z joint from which cavitation originated. And so we MRI scanned the subjects first, then we placed the accelerometers, did a spinal manipulation, and then scanned them a second time, and then correlated gapping with cavitation and found that indeed cavitation was related to Z joint gapping. If a joint cavitates or has that popping sound, it has gapped, but it doesn't quantify how much it's gapped. Some joints don't cavitate, but they gap just as much as those that do. So we believe that it's the cavitation sound is due to the speed with which the joint surfaces separate. And we have some preliminary evidence to support this. And so we've identified that joints that hypercavitate, they cavitate multiple times, those joints are actually narrower before manipulation than others. So now we speculate, so this is now speculation, that these joints have increased muscle tightness around them. And so during the manipulation, that separation occurs more quickly as the force of the muscles is overcome by the thrust. And so they separate quickly and create that popping sound. And so now I further speculate that may indicate that the joints that cavitate may be the ones that benefit the most, because those are the joints that have increased muscle tightness around them. Now, that last statement is speculation, and more work needs to be done to validate that statement. But the previous statements were based on our results. Since this time, that process got us interested in vibrations and sounds that emanate from the Z joints, even during normal motion. And so crepitus, and maybe sometime you've moved your shoulder around or turned your head or moved your knee, and you hear this crunching sound. So that's called coarse crepitus. And there's also fine crepitus, which we cannot hear, but are vibrations, very low amplitude sounds coming from the joints almost all the time. And that's been related to decreased joint lubrication. And so we're hypothesizing and pursuing work to look at crepitus, fine crepitus, as a biomarker for zygapophyseal joint dysfunction. So we currently are working on a grant related to that, and we published a paper on that and have another one coming out. And now we're combining that with diagnostic ultrasound rather than magnetic resonance imaging, because diagnostic ultrasound allows us to view the joints in real time. And so here you can see right here is the zygapophyseal joint space. So if you keep your eye on this during the manipulation, especially right at the top, you can see it the best. Okay, keep your eye on the ball there. Now notice that the surfaces continue to separate. So that's Z joint gapping. We found that the joints separate maximally 10 seconds after the manipulation. 10 seconds after the manipulation. So what you just saw was $1.7 million worth of research. It's very expensive to do this. The human studies were funded by the federal government, the National Center for Complementary and Integrative Health. The animal studies funded by NCMIC, a private foundation. We're very grateful for that. And also very grateful for all of the research assistants and co-investigators. It took over 30 individuals for that lumbar human MRI study. So it's an incredible team effort. So we talked about movement of menisci and breakup of adhesions. The last theory related to how manipulation affects the zygapophyseal joints is stimulation of mechanoreceptors in the capsule and related responses. So here we can see a drawing of a Z joint capsule, and here it's been opened up, and so you can see the 3 layers of the capsule with the intersynovial lining. So Weick was a medical neurologist who studied articular neurology, and he studied the zygapophyseal joint innervation very intensely. It's been found that the Z joints receive triple innervation from the medial branch of the dorsal ramus of 3 contiguous segments. This actually becomes relevant clinically as well, because in a lot of the pain clinics that are being developed by anesthesiologists, they are doing facet joint denervation, medial branch neurotomies, and so they need to denervate 3 contiguous medial branches in order to denervate a single Z joint. By the way, these nerves also innervate the semispinalis, multifidi, and rotatories muscles. So you are denervating muscles when this occurs. Theoretically, the nerves will grow back, but they do not grow back the same as before. So I think it's reasonable to say that let's try some manual procedures or exercise. Many of you are interested in therapeutic exercise before going that route, but sometimes that is necessary. But at any rate, Weick was very interested not only in the innervation of the Z joints, but the receptors, the sensory receptors within the Z joint capsule. He found 3 types of these. Type 1, he called the first type 1, they're in the outer Z joint capsule. And these are mechanoreceptors that are firing all the time. So right now you're trying to sit as still as you can. Pop, 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 pop. These are firing all the time. Type 2 receptors are dynamic receptors deeper within the Z joint capsule. They fire with motion. So you're looking at the screen, pop, 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 and then you look down to take some notes. Pop, 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 pop. You get additional firing from those type 2 receptors. Type 4 receptors were nociceptors. They transmitted painful stimulation or stimulation that's interpreted as painful, and they fire just before tissue damage occurs. There are type 3 receptors. Weick could count better than this, but they were not found in the Z joints. They're found in other joints of the body. So Weick and also other small things become important when we think about this theory. There are these tiny muscles, the interspinales and intertransversarii muscles between spinous and transverse processes respectively, that have been found to have up to 25 times the number of muscle spindles as other joints in the body. 25 times the number of muscle spindles. That's a lot of muscle spindles. So these are probably proprioceptive organs. That's probably their function, is to tell the central nervous system, provide information to the central nervous system as to the position of the vertebra in space at any given time. So Weick hypothesized that spinal manipulation stimulated these type 1 and type 2 receptors that we described in the capsule. And others since then, Joel Picard and Bill Reed and others have talked about this, the muscles of the spine also doing this same thing. So Weick said that manipulation would stimulate these type 1 and type 2 receptors, and that would have two effects. The first is what he called a pain suppression effect via a Melzack-Wall gating mechanism, where these rapidly conducting fibers from the mechanoreceptors dampen the input from nociceptors, pain, at the level of the dorsal horn of the spinal cord. So pain suppression neurologically. And then the second effect, and there, by the way, have been a lot of studies that have validated this, both in animals and humans now. And then Weick also said the second effect is what he termed a reflexogenic effect, whereby manipulation would stimulate these mechanoreceptors, and that would reflexively relax the erector spinae muscle at the same level of spinal manipulation, and several levels above and several levels below that level of manipulation. And there have been several studies on animals and more recently on humans at the University of Utah, and really good work done by a physical therapy group at the University of Utah, showing this type of effect. Okay, so back to our theoretical model, we say the Z joints become hypomobile for a variety of reasons. That results in adhesion formation, manipulation gaps the joints. Now this gapping, therefore, has two effects. This neurophysiologic effect, type 1-2 receptors and the muscle spindles of the small muscles, and then that biomechanical or anatomic effect breaking up the adhesions. Now these are probably not mutually exclusive. They're likely happening both at the same time in most individuals. So again, that neurophysiologic effect, you stimulate the mechanoreceptors, and that then decreases pain and relaxes muscles. And then we break up the adhesions. Breaking up adhesions reestablishes joint motion and slows or reverses the degenerative changes. Well, we talked about a lot of good things that happen when we manipulate the spine, or talked about its benefits. But whenever we talk about a procedure, we need to balance the risk versus the benefits. And so I'd like to discuss briefly risk versus benefit of spinal manipulation. First, that procedure needs to have benefit, or it is too risky by definition. Shakel and all reviewed all of the literature on lumbar manipulation as early as 1992, and this has been very heavily studied in the last several decades. There are now, this is a meta-analysis of the studies that were done there, a meta-analysis being a study of studies. And now there have been over 20 meta-analyses, there have been hundreds of studies, 20 meta-analyses. Now there are umbrella meta-analyses, which are meta-analyses of meta-analyses, and they all come out the same, showing benefits of manipulation, short-term and long-term, follow-up of 3 years, in both acute and chronic low back pain. Same is true in neck pain. Many studies have been done on neck pain. Here are a few, and the citations, the references are in your notes. They're provided. The most extensive assessment of neck pain and manipulation was done by the Bone and Joint Decade Neck Pain Task Force, which was a multidisciplinary and international group studying neck pain. They concluded that spinal manipulation, when combined with therapeutic exercise, as many of you are interested in, that combination is the best first-line treatment for the vast majority of neck pain. And current guidelines for treatment are reflecting that. Also, headache. Cervicogenic headache or vertebrogenic headache. There's been a lot of work beginning in the 70s and then more recently have shown benefits of spinal manipulation for vertebrogenic headache and muscle tension headache. Now, regarding risks, Carnes did the most extensive review of risk related to spinal manipulation. Walker more recently buttressed that work. Carnes concluded that minor adverse events were quite common, that approximately 50% of individuals receiving a spinal manipulation report soreness within 24 hours of the manipulation, and it leaves within 72 hours. The soreness is about the same as occurs with rigorous exercise, and interestingly, it's about the same as for sham treatments. Now, for sham treatments, in clinical studies of spinal manipulation, frequently what's called a sham manipulation is given. That's where the choreography of the manipulation is the same, but the thrust is dramatically less forceful, to the point where clinicians have agreed that there's no therapeutic benefit. And yet, those individuals report the same amount of soreness as those that receive the full manipulation, but those that receive the full manipulation have improved significantly more and faster. So maybe it has something to do with positioning. More work needs to be done to understand that phenomenon. major risks following spinal manipulation are extremely rare. And we'll put this into perspective a little bit. Bandolier is a journal that was started by University of Oxford medical professors in the United Kingdom. They are proponents of informed consent. They feel that for any therapeutic procedure given by any doctor, that the patient should be informed as to the relative risk. And they recommend comparing the risk of a therapeutic procedure to these life events, which they feel most people can relate to. And so this is in your handout as well. And so, for example, the risk of dying from a lightning strike is 1 in 65,000. Now, the most serious risk associated with lumbar manipulation, low back manipulation, has been associated by a few as cauda equina syndrome, where a disc bulges in the upper lumbar region, pushing against those neural elements of the cauda equina, resulting in bowel and bladder dysfunction. Serious business. Shaquille reviewed all the literature on this as well and found that the incidence to be 1 in 100 million. So that is extremely rare. In fact, you are 20,000 times more likely to die of a lightning strike than this incidence reported by some as cauda equina syndrome with manipulation. However, you're 7,400 to 37,000 times more likely to get cauda equina syndrome from surgery than from spinal manipulation. It is a real risk in lumbar surgery. Now, others, the major risk that has been associated with cervical manipulation is vertebrobasilar accident, which is a type of stroke. And it can lead to death. It usually does not. People usually recover fully, but it can. And the incidence reported in the general literature for this is 1 in 1.5 million. Now, and Hurwitz and all did the first review of the literature on this. Many others have studied this since. This is probably the most heavily studied area of spinal manipulation. At any rate, so you're 30 times more likely to die of a lightning strike than this incidence. However, Boyle and all looked at the incidence of vertebrobasilar accident in the general population, and they found that the incidence is the same. So this